right. I think out of respect for everybody's time, we're going to get started here. Welcome and thank you so much for joining us on this webinar. We are going to be discussing overcoming joint pain using the Mako technology. Today, it is hosted by the St. Cloud Surgical Center and presented by Dr. Andrew Mulder, who is part of St. Cloud Orthopedics. So thank you all so much for joining us on this event. We're looking forward to providing some valuable information today. So my name is Sydney Bofferding. I am a marketing consultant with Gaslight Creative, and we work in conjunction with the St. Cloud Surgical Center as part of their marketing team. So I will be your moderator for this event. I'll be your host for this event, and I'll be working in conjunction also with Dr. Andrew Mulder to continue this webinar. So this event will be about an hour and a half long or so, ending promptly at 7:30, give or take, a little bit in there, kind of depending on how many questions we have or anything like that does pop up. If you are joining us on Zoom today, we do have a couple of housekeeping tips that I'd like you to keep in mind. We do ask that you are muted at all times. This does allow us to keep our focus on Dr. Mulder and the things that he is saying, and to make sure that everybody else can have that information. Do please have your video off as well. That would be great, just so we again can focus on the speaker. If you are unaware of how to do this, on your screen you should see if you hover over it, you should see a mute or a stop video button down in the bottom left. If you see a red strike through that already, it is already muted or your video is turned off and you are good to go. If you do not see that, then just go ahead and click that for us. I do believe that everybody on here is doing well so far. If you happen to see me mute you or turn off your video at any time, it is just me. Please don't be alarmed. So we do want you to know that in the top right-hand corner on Zoom, there's an option to view the group view or the speaker view. We do encourage you to use the speaker view for this particular webinar so that we can focus again on Dr. Mulder and his presentation, as he will have slides. So again, if you hover over your screen with your mouse and go into the top right, it will say view or speaker with several different boxes. Just click until you have the one that focuses right on the speaker. Immediately following Dr. Mulder's presentation, there will be a question and answer portion. And so we are actually going to have that just be done through the chat section on Zoom. If you are unaware of where this is, if you again hover over your screen at the very bottom in the middle, there is a chat function that you may click. And once you click that, you will be able to insert a question. You can send it directly to me, to Dr. Mulder. But either way, at the very end, I will provide those questions to Dr. Mulder at that time. So please feel free to ask those questions throughout the whole presentation. Just know that we will be answering it at the very end. So again, I'd like to introduce Dr. Mulder, and this is his presentation about overcoming joint pain using the Mako technology. So just a little bit about him, and then I'm going to let him really take over because I feel like he's the expert on him. So yeah, a little bit about what I know is he is a board certified hip and knee surgeon for the St. Cloud Orthopedics. He did receive his doctorate at the University of Minnesota School of Medicine in Minneapolis. And Dr. Mulder uses a personalized approach to hip and knee replacement surgery using a minimally invasive muscle-sparing techniques, computer navigation, and robotic assistance when appropriate. Dr. Mulder is the author of multi-hip and knee-related publications and is an active member in the American Association of Hip and Knee Surgeons. So I'm gonna let you take over from here, Dr. Mulder. I'm gonna mute myself and I'm gonna turn off my camera and let you take over.
All right, thank you very much, Sydney, for that introduction. All right, there we go. As Sydney said, my name is Andy Mulder, and I am a specialist in hip and knee replacements and work at St. Cloud Orthopedics in close conjunction with St. Cloud Surgical Center, where we do a lot of our outpatient joint replacement surgery. And so what I'd like to talk about today is like to talk about robotic joint replacement surgery. And as of right now, that's limited to hip and knee replacement and partial knee replacement surgery. Probably down the road on the horizon, I expect we'll be replacing other things with the use of robotic assistance. As for right now, the talk is limited to hip, knee, and partial knee replacements. So by way of a little more background, I'm somewhat local. I was born I lived in Renville, Minnesota originally. That's west of the Twin Cities on Highway 212. I went to the University of Minnesota for medical school. I did my general orthopedic training in Detroit, Michigan, and did a year of hip and knee replacement training at the Cleveland Clinic in Ohio. And in 2013, I found my way to St. Cloud and have been practicing here ever since. So I'm going to go by a little bit of background first. I'd like to talk a little bit about why your joints are important to me, talk about what arthritis is, how it's treated, as well as kind of what we're here for, which is the robotic assisted surgery. So I care because arthritis is extremely common. It's the second most common chronic condition in the US after sinusitis. So for everyone that goes in with their typical fall and winter sinus infection, arthritis is just behind in terms of conditions, most common in elderly people, which makes sense. Almost half of people will at some point get knee arthritis that hurts. That's not just people that have some, it doesn't bother them. Almost half of us will get painful knee arthritis in our lifetimes. And almost 1/3 of people over the age of 70 have arthritis of the hip. So it's extremely common. Arthritis more frequently limits activity than does heart disease, cancer, and/or diabetes, and affects over 30 million people in the US. In this study, we can see that where we are, this is a little bit of an old slide, so this circle should be moved to 2020. We're doing about 1.5 million joint replacements a year. By 2030, just 10 years from now, we expect that we'll be doing, in terms of knee replacements, almost 3.5 million, and in hip replacements, almost 500,000. So it's an extremely common surgery, particularly knee replacements. I care because arthritis is extremely expensive. The total cost to the US and the medical system is over $82 billion a year. That's the medications we use, the cost for treatment, pre and post surgery, and including lost productivity at work. Arthritis is really a chronic condition. You don't wake up one morning with arthritis. It happens over time. It's where the end of the bones, where the bones meet and move together, called the joint, where the smooth, slippery, gliding cartilage gradually breaks down, which causes the bones to rub against each other, can lead to stiffness, pain. We don't know exactly why it happens. Certain reasons are obvious. That is, if you're in a car crash, you severely damage the cartilage in a hip or a knee, then you go on to develop arthritis earlier than you otherwise would. That's called post-traumatic or after-injury arthritis. There's also inflammatory arthritis like lupus or rheumatoid arthritis. That's the body kind of reacting to itself. That's less common, but still we see it on occasion. The most common form of arthritis that we see is so-called osteoarthritis. It's more kind of the normal wear and tear, age-related. It's the most common form of arthritis that we see. Joint. So the white part here, synovial fluid, that's the smooth, slippery fluid in the joint itself. In the cartilage itself, you can see this pink layer down here as well. The very bottom layer labeled bone is this darker red. These purple spots are the cartilage cells. As you can see, they're fairly isolated. It's hard to get healing to cartilage that's damaged. It's pretty isolated. So in this picture, we can see in the upper left of your screen is normal cartilage, and looking at it with a camera in the knee, you can see the smooth, kind of glimmering surface, almost looks like linoleum. Whereas the upper right picture shows the microscope picture with the creases, the fissures, the defects in the cartilage, and that would look more like the picture on the bottom. Almost looks like an old street instead of nice smooth linoleum. As we age, the water content goes up in the cartilage. It's almost like a pothole. In the winter, it fills with water. The water freezes and expands, and the similar thing happens with the cartilage. So that's what it looks like. What does arthritis feel like? Well, it's different with everyone, depending on where it is. Generally speaking, it's pain, it's achiness. You can get it in the knee, the thigh, the calf, the hip, the buttock area. It often makes it difficult to walk. With hip arthritis in particular, a common complaint is that it's difficult to get your shoes and socks on, clip your toenails because the hip is so stiff. Sometimes it's worse in the morning or after you sit and rest for a while and get up and start moving again. Weather change is absolutely affected as well as the barometric pressure comes and goes. Well, how do you know if you're at risk for arthritis? Well, there's some components you can't control. If your mom, your dad, your uncle, your aunt, and all your cousins had a hip replacement, well, you may be in for that as well. We know that obesity plays a role. So people that are overweight tend to get arthritis more so than people that aren't. Injury can certainly cause it. One thing we can't control is age. If you're over 65, you're probably going to have some form of arthritis. Well, if you have a sore hip, sore knee, how do we figure out what it is? How do you know if it's arthritis? Well, I think as important as anything is the history and clinical exam. The history being you talk about when your symptoms started, what it feels like, how it affects you, what makes it better, what makes it worse, etc. And then an examination of the joint that's affected may show me that there's some deformity, some bending, there's some stiffness in the hip or the knee that would be typical for arthritis. We'll often get an X-ray of the affected joint. Other imaging like CAT scans and MRI scans to diagnose arthritis are rarely needed. Blood tests would be reserved for arthritis such as rheumatoid arthritis and or lupus, something to that effect. So more the inflammation type arthritis. That's not something we often get. Arthritis looks fairly typical on an X-ray. So if we look at these X-rays, this is an X-ray as though the person is standing up looking at us. So that would make this the right knee over here, if you can see my cursor. If not, it's on the left side of your screen. This is the left knee. You can see the thigh bone here, or the femur. You can see the shadow of the kneecap or patella right here. You can see the shin bone or the tibia right here. The gap or the space in between the bones is where the smooth, slippery, gliding cartilage lives. It shows up as empty space on the X-ray. If you compare that to this gentleman who has the unfortunate situation where he's got arthritis in both knees, kind of in a different area, his left knee might look like this, where he's bow-legged and the arthritis is on the inside part of the knee. The vast majority of people have this kind of arthritis in their knee. His other knee might look something like this, where there's arthritis on the outer part of the knee. In either case, you can see that no longer is there a gap between the bones, so we know that the smooth, slippery, gliding cartilage has to have worn away, and that's really what arthritis is, just the wearing away of that cartilage leading to pain, stiffness, etc. MRI scans are good at showing soft tissues, cartilage, ligaments, again, rarely needed to diagnose knee arthritis. CAT scans show us fine detail of bone. They're important in planning for surgery, but I find them not very important in diagnosing knee arthritis. In a hip, the hip is like a ball and socket joint. So here's the ball of that hip joint. This is the femur or thigh bone. This is the hip socket here. On the left side of your screen, you can see there's a lot of space between the ball and the socket, indicating again, there's that smooth, slippery, gliding cartilage. The picture on the right shows that that ball is no longer round. It's sort of worn down and there's no gap between the ball and the socket, indicating arthritis. So your hip's been hurting, you've been limping around for a while, you came in, we've diagnosed arthritis. Well, now what do? Well, there's some things you can do, just like any other mechanical system. The less weight, the less pressure on it, the better it feels. Weight loss can certainly help, though it won't cure arthritis. We know that joints like to move. Maybe you can't hike, but you can walk. Maybe you can't walk, but you can bike. Can't bike, you can swim. So moving the joints is a good way to prevent a knee replacement or a hip replacement. Lots of medications can be used, mostly over-the-counter medications like Tylenol or ibuprofen. There are injections of all sorts. There's steroid injections or cortisone injections. There's lubrication type injections. Other types of injections like stem cells, I find for bone-on-bone arthritis are probably not a good idea. They just don't work and they're expensive. For mild arthritis, that may be a different case. Surgery is really the last resort after you've tried everything we can think of. Well, how do you know if you're ready for surgery? Well, if the answer to the question, can I live with the pain, is, well, I can't hike for 10 miles anymore. I can only hike for 5 miles and then my knee's a little sore. Well, that might be something you can live with. Have you quit all the activities you enjoy because of the pain in your knee or hip? Have you tried anything to prevent the pain or the symptoms? And how will surgery improve your condition? What's the expected outcome? Are you healthy enough? You need to make sure that your heart, lungs, kidneys are all working and functioning. Any dental work that needs to happen should happen beforehand. Do you have time to have a joint replacement surgery? Is your work going to let you take time off? Are they going to let you come back with restrictions? And finally, who's going to help you after the joint replacement? It's pretty hard to recover on your own. To have a support system in place is vital to your recovery. I think the biggest thing is expectations. If you think one thing is going to happen and I expect another thing is going to happen, and you meet my expectations but not yours, that's going to be disappointing. So really, for me, the images, that is typically the x-rays, has to show arthritis that has to match the story you're telling me and match the exam that I do. And if that all matches, really, you're a good candidate for hip replacement. There's no age cutoff, low or high. It all depends on the situation, and it depends on what the risks are. Once we've determined that the benefit may outweigh the risks, then it's time for surgery. Well, I always think it's to look at where we've been to compare it to where we are now. Some early attempts at hip replacement included this type of device where you sort of put a big bolt through the hip, a metal socket. That worked well for a while. In the early 1900s, they'd simply just remove the ball and you'd kind of limp around with scar in your hip. Didn't work great, but somewhat helped. There were these acrylic sort of replacement femoral head or ball that was used in France in the 1940s. Also in the United States, they had this metal cap they just simply placed in the hip socket and let the hip work with that. These were all okay, but they weren't very durable. It wasn't until the 1950s when my angel, John Charnley, invented kind of the modern hip replacement, where it's two components. There's the ball that's attached to a rod that goes in the thigh bone and a new hip socket. This is a picture of one of those original hip replacements. This is a picture of a modern hip replacement. It really doesn't look that different. In John Charnley's time, all of the parts were cemented into place, which is very reasonable. Nowadays, a hip replacement will more typically look like this, where the hip socket and the part that goes in the thigh bone that holds the ball is what we call press fit. That is, it fits snugly in the bone and the bone grows onto the metal over time rather than using cement. There's all sorts of shapes and sizes. They all work well and they all have good use depending on the situation. Knee replacements have come a long way as well. This picture in the center is sort of the early modern knee replacement. In the past, they've tried putting these kind of metal runners in place. They've done things where they put pig bladder, Teflon, ivory, all sorts of things, cut out the arthritis. Really, that wasn't until the 1970s where the kind of first modern knee replacement came into being. Here's another example of a hinge. You just put a rod up the thigh bone, down the shin bone, and walk around on that. Again, these all worked well, but didn't last very long. This is a modern knee replacement that should last you 20 or so years. The knee replacement has two parts. There's a part on the end of the thigh bone, sort of a metal cap on the end of the thigh bone. Oftentimes we'll resurface the kneecap. That is, you shave down the underside of the kneecap and replace it with this plastic button. And there's a metal tray that sits on top of the shin bone with a plastic liner in between those. Partial knee replacements have kind of come in and out of vogue. We know that one of the criteria for them working well and lasting is accurate placement, which robotic assistance helps with. We'll cover that later. And that's really when only one part of the knee is worn out. You can see in this picture a full knee replacement versus a partial. Partial is a little bit less invasive, a little bit more natural feeling potentially, and a little bit quicker recovery. So in certain instances, that can be a really good option. A hip replacement looks like this. There's basically two parts. There's the hip socket side, a plastic liner that goes in there. That's the new smooth surface. A ceramic ball that's attached to this titanium wedge that sits in the hollow part of the thigh bone. And here's an example of what one looks like. Sometimes screws, sometimes no screws, depending on the situation. So a lot of people come in and say they've heard about a new kind of surgery, a minimally invasive, muscle sparing. And so I think that is true in some ways, but can be a bit of a misnomer. The most typical thing people are talking about is this anterior hip replacement. In that hip replacement, you go between muscles, and there are some small muscles that are typically released as well. Generally speaking, it's a little bit less invasive. More typically, an incision will be made more on the side of the hip, curving towards the buttock. That's how I learned originally. It's a very good way to get at the hip. You can do anything you need to. It's very familiar to most surgeons and has great outcomes. And so really, you can do a very minimally invasive posterior hip and a very maximally invasive anterior hip. The other most common way is so-called lateral. That's sort of the middle ground. It's got some of the benefits of both, and the incision is usually straight on the side of the hip. Doesn't matter how you get at the hip, as long as it really doesn't matter. There's nothing new about the so-called anterior approach. Sometimes that anterior approach is called the Smith-Peterson approach. He died in 1953, and so it was doing it in the 30s and 40s. The previous of sort of computer assistance or navigation was a system where you would place trackers in the bone, and during the surgery itself, you would create a picture of the knee. You'd tell the computer what the knee looked like, and then based on that picture, it would guide you. And so what we do is we start in the office, we plan, we say, okay, this is what size parts we expect to use. During the surgery itself, we've got a digital wand that traces the bone and tells the computer what the bone looks like. Then we use that information for the computer to help us see where we're at. The computer system does not guide our hands. It does not prevent us from doing anything, just gives us numbers and feedback as we go. So there have been multiple studies that say basically we know that when we use this navigation system, we're more accurate in placing the parts where we need to be. We know that, at least in Australia, from 2003 to 2012, having to redo a knee, the rate was less high when you use the navigation system, like I described, than not. So we know that the navigation aligns the knees better. That's been fairly well shown. Robotic assisted different in that we create an image of the knee pre-surgery CAT scan that gives us a 3D model of your knee. And so the computer already knows what your knee looks like. And then it uses a robotic system to actually physically guide and limit where we can do our work. So, the question is, do we need robotics? Well, Henry Ford was pretty successful in the early 1900s robotic system. Nowadays, you'd be hard pressed to find a factory or an auto plant that doesn't have robotics, just for the reproducibility and predictability. So in joint replacement surgery, we know that we can put the parts in a better position. This is important because we're not quite as good as we think. As orthopedic surgeons, we like to think that we're pretty good, pretty accurate. Using traditional techniques in almost 2,000 hips, a study of some well-known hip replacement surgeons on the East Coast found that they hit the mark of where they thought the parts would be only about 50% of the time. And that when you use so-called minimally invasive surgery or a smaller incision, that created the most inaccuracy. When we use, when we use image navigation in the hip, we know that the hip socket goes where we want it more often than if we don't. So we know for sure that some type of computer assistance lends itself to more accuracy. We know that it is likely better to have more appropriately positioned parts, but we don't know if that's going to lead to longer lasting hips and knees and fewer complications. So when we do a knee replacement, this is what it's going to look like when we're done. What we do is we try to create equal gaps with the knee bent and the knee straight. Here's another example of that. And what we're doing is we're shooting for some specific guides, essentially. So I'm going to skip over these to get to this slide here. Generally speaking, we want this tibial tray, or this platform on top of the shin bone, to be about 90 degrees to the long axis of the tibia. We want the thigh bone to be about 5 or so degrees past 90 degrees, and that creates our even spot. we want there to be a little bit of slope. That is, we don't want in the sideways view, we don't want the tibial tray, that is the platform on top of the shin bone, to be flat. We want it curved back slightly. We also want the metal parts to match the natural curve of the end of the thigh bone, not to be sticking out too far or indented too far. We also want this kneecap to track right in the middle of the end of the thigh bone. So we've got our goals. What we're trying to avoid is this. We're trying to avoid cutting something bad over here. We're trying to avoid digging into the bone, which leads to fracture. We're trying to avoid cutting this angle into the bone, because none of those things are going to do well. The robotic system allows us to do that. I'm going to switch over here to a video of what a knee replacement looks like. Bear with me as I switch over to that. So let's see if this works here. So this is a video that Stryker put together, and it talks about total knee, total hip, and partial knee replacements. Specifically for total knee replacement, this is the robotic unit, weighs about a ton. You wouldn't want to drop it on your foot. It's about 3 feet tall. The business end is on the end. That's what I'm concerned about. The type of knee replacement I use, I don't get paid to use. I use it because it's got a good track record. Most people at 10 years still have that same knee in place. Over 2 million have been done. This is old information. It's much more than that at this point. You can do partial knee replacements, total knee replacements, hip replacements. What I'm focusing on for this is the total knee replacement. This is an example of what a CAT scan looks like that gives us a 3D model of your knee. So I know what your bone looks like ahead of surgery. I'm not telling a computer what it looks like. During the surgery itself, before surgery rather, I'm looking at this plan. The green represents the metal parts. I can adjust the size. I can adjust the position to match your bone. During the surgery itself, through an incision on the front of the knee, I'm using that blue digital probe to match up the bone to the CAT scan.
Dr. Mulder.
Then during the surgery, the really nice trick is I can push on the knee, bend it, straighten it, and the robotic system tells me, okay, if I put the knee in that way, this is what it should feel like when I'm done. And if I think it's too tight here, too loose there, I can make adjustments before I cut the bone, kind of like
Dr. Mulder.
You can't put the hair back.
Dr. Mulder.
Once I'm ready, this saw that's connected to the robotic system comes in. I'm looking at this cartoon version on the computer. It gives me a virtual boundary. Blood vessel and nerve back there are safe because the robot will stop me from cutting out there, stop me from cutting anything I don't want to. You'd really have to work hard to trick the robot into doing anything too stupid. Once we've prepared the bone, shaved off the arthritis, we put the metal cap on the end of the thigh bone, the plastic liner, and the metal tray on the top of the shin bone. And that's a knee replacement with robotic assistance.
Dr. Mulder.
Switch back to my talk. That surgery typically takes me about 45 minutes or so. And most often people are able to leave the same day. I'm going to skip ahead to that slide. Bear with me a moment. There's Sir John Charnley, my favorite guy. All right, so skipping ahead here. All right, I'm not sure what you all can see. For some reason, my computer isn't letting me go to the full screen. So you'll have to bear with these images for now. So in addition to in knee replacement, we also have a goal that we're shooting for with hip replacement surgery. We know that we want this green line represents the legs being the same length. We don't want the leg too short or too long. We know that generally speaking, the hip socket should be at about a 45-degree angle. And we know that on the sideways view, this white line represents the bone, the blue represents the metal hip socket. We want it to line up with the bone, not stick out too far one way or the other. What we're trying to avoid is this. This is not a patient of mine, it's from the internet. The ball is popped out of the socket. That's not going to be very functional. Here's another example of that. Here's an example of hip replacement that was basically the hip socket was put in almost backwards. You'd think that'd be impossible to do, but it's easy to get tricked, especially when you've got a lot of extra tissue around the hip. So really that's what we're trying to avoid. The way we do that is with, going to another video here, is with the robotic system that again lets us plan ahead of time. All right. those are my kids, if you got to see those. They're a little bit older now. Trying to get back to that screen. There we go. And so this is a video of a hip replacement surgery. So again, here's the robotic system. That's me standing there.
Dr. Mulder, we cannot see the video.
And this would be a typical setup. We've got a couple screens for reference, the robotic system itself. Again, we start with the 3D CAT scan of the hip. The CAT scan isn't used to diagnose arthritis, it's used to plan ahead of time. I'm looking at your actual anatomy and not a generic model. I'm not guessing on sizes. I can position the parts, select the angle, select the size. I know ahead of time what I'm going to use. During the surgery itself, you'll either be lying on your back or lying on your side. We use this digital wand to mark out all the points on the thigh bone. That tells us at what level to resect or remove the ball of that ball and socket joint. With that ball out of the way, that gives us access to the hip socket. In a similar fashion, we look at the computer screen, look in your actual hip. We want to match the CAT scan to your bone. Once we've assured that there's a good agreement between the bone and the CAT scan, that essentially locks the robot into your hip. Once we've done that, the robot is brought in. I'm doing the work. I'm creating, excuse me, it looks like my screen sharing paused for a moment. Okay, looks like I'm back on. Sorry for that interruption. I'm still kind of figuring this all out, just like many of you may be. There's my kids again. Okay, back to the video. So the robotic system is directing me. It's preventing me from painting outside the lines, essentially.
Can't see.
All right. So for some reason, I don't think you're seeing that video that I'm presenting. In any case, what the video was showing is, it was showing that there we go, that's where I left off. So this is the hip video, this is what we're trying to avoid. So what the video showed was, like in the knee, the robot is guiding me. It's creating a virtual boundary so I can't paint outside the lines. I don't think that someone off the street could do a hip replacement using the robot. You need to know what you're doing. You need to know why you're doing it. If you want the robot to do something stupid, it will let you. So it's important to know and have experience with that. And so if you have a surgeon who's done two, they may have a little bit more challenge than someone that's done 2,000. So once you've had your robotic hip replacement, we know the x-rays are going to look great because we know exactly where the parts are going to go before we even leave the operating room. And after surgery, a lot of people want to know what to expect. Will it hurt? Yes, it absolutely will hurt. There's no way that I know of to do surgery and have zero pain. What is typical is your pain is well controlled to the point where it's reasonable and tolerable, sometimes with just over-the-counter medications, sometimes with prescription pain medications from anywhere from a couple of days to a couple of weeks. So yes, it will hurt, but generally speaking, it's tolerable. Will you have to stay in the hospital? Well, the answer 10 years ago was, yeah, you're in the hospital for 3 days, a week, then you go to the nursing home for a month and recover. That really has changed a lot. We found that recovery is often better at home. It's often safer. There's less complications. And so it's very typical for people that are pretty healthy, have help at home, to have a surgery where they come in and leave the same day. It's not necessarily a requirement based on your certain situation, but it's the norm. In fact, Medicare now considers hip and knee replacement surgery an outpatient surgery. That is, they expect, unless you have a good reason not to, that you'll go home the same day. After a knee replacement surgery, physical therapy is ubiquitous. Everyone gets physical therapy 2-3 times a week for 4 to 6 weeks. Knees are stiff, sore. You need help getting them moving. Hip replacements, not so. They just don't get stiff. They rehab very well doing exercises on your own and just giving it time. Blood clots are a known complication of hip and knee replacements. The result, or the risk of a significant blood clot is less than 1%. Generally speaking nowadays, for low-risk people, a baby aspirin once or twice a day is sufficient and effective. I tell patients that after a hip or knee replacement surgery, particularly on the right side, You need to wait a minimum of 2 weeks before you can drive. There have been studies that show it takes about that long for the foot pedal work to recover. You can't be taking prescription pain pills, and you just have to be able to do it safely. Typically speaking, you'll see your doctor about a month or so after surgery for a checkup. You won't be doing perfect by then, but you should be well on your way. As I went over at the beginning of the presentation, knee and hip replacements are expensive. It's a big cost to society, cost to the medical system. There's significant benefit in terms of quality of life that's been shown over and over. What you may not realize is where you have your surgery done may affect your pocketbook. We talked about doing an outpatient surgery, that is where you leave the same day, which is very common now, versus inpatient. Your insurance company and or Medicare and the hospital or surgical center may view those things differently. Generally speaking, it's more cost effective to do a joint replacement at an outpatient surgical center, such as St. Cloud Surgery Center. That may depend on your insurance, may depend on other things. And the surgery center is a good resource for knowing just how much it's going to cost you out of pocket, as well as your insurance company. I think it's important that you know ahead of time how much you're going to be on the hook for, because you can have a great result surgically and be pretty unhappy if you're stuck with a big bill. So ambulatory surgical centers or outpatient surgical centers are becoming more common. We can do increasingly complex surgeries like hip and knee replacement really quite easily. We've got better results with pain control, medications, nerve blocks, things like that, that make things that weren't conceivable 10 years ago very commonplace now. Oftentimes, Medicare is charged significantly less in a surgery center versus a hospital. The patient may save between $200 and $1,200 depending on the surgery and the insurance plan. And so really, depending on what your deductible is and your plan, it may be a more cost-effective option, but it's certainly not a requirement. We know that outpatient surgeries, such as at the surgical center, have slightly better results in terms of safety, infection rates, et cetera. It may be because people that are motivated, healthy, that want to get going are coming there preferentially over people with more medical problems, but still, overall, the rates of complications are slightly lower. Since 2015, when we started doing joint replacements at the surgical center, we have a less than 1% hospital transfer rate. That is less than 1% out of about 1,500 or almost 2,000 patients now have had to be taken to the hospital from the surgical center, usually because of sort of a freak heart rhythm and not typically related to the surgery itself. So that's a very quick summary of knee and hip arthritis, what that might mean to you. There's some good ways to treat hip and knee arthritis, a lot of which don't involve surgery. And so the surgical center combined with robotic assisted surgery, in my experience, has worked very well for accuracy and consistency. And really, no matter where the incision is made, what technology is used, as long as you and your surgeon have a good rapport and they know what they're doing, I think the chances of improving your quality of life are significant. And so at this point, we'll open it up to questions. I think what I may do is end my screen sharing. That way we can have Sydney come back in and field some questions. I can start actually now. There's one question I have that asks, what are the limits with activity after a surgery and for how long? Each surgeon will have a little bit different take, but generally speaking, after a hip or knee replacement, the idea is after a hip replacement is you can expect to use a walker or a cane anywhere from a couple days to maybe 2 or 3 weeks after surgery. During that time, you can sit, stand, walk, go up and down stairs. After 2 weeks, you can drive. By 6 weeks after a hip replacement, you should pretty much be back to doing everything you have to do. By 3 or 4 months, doing everything that you want to do. Knees are a little bit slower. I typically tell people it's a walker or a cane anywhere from 3 to 6 weeks. By 6 weeks, you're still going to be stiff and sore and working through some of the kinks. By 3 to 4 months, you won't be fully recovered. You should be back to doing almost everything you want and thinking about the knee a lot less. It takes a good year to fully recover from a knee replacement. In terms of activities, the only thing I'd recommend against is jogging for fitness. Otherwise, pickleball, tennis, biking, hiking, swimming. I've got people that are roofers, construction workers, office workers. Surgeons differ on this, but after a knee replacement, I say if it doesn't hurt to kneel on your knee, you can kneel all day. I don't feel like it does any harm. However, it's common after a knee replacement just not to like that sensation of kneeling. So that may be something that you deal with long term. So I'm going to stop my screen right now and then give it back to Sydney for any more questions that we might have. And I apologize for the brief interruptions. I'm at the office where I think the internet is okay, probably user error. So back over to you, Sydney.
Great job, Dr. Mulder. Thank you so much. Yeah, sorry.
Put these squeezers on your lower legs.
Oh, there's a video.
As soon as you wake up from surgery, I want you to start moving your feet up and down, and we have you move both feet up and down. The other thing we do is we try to get you up walking right
Dr.
away.
Mulder, are you able to mute that
we do
video?
all 5 of those things to help prevent blood clots. Now, whenever you have an artificial hip, you can
So am I,
pop
oh my
the
goodness.
artificial ball out of the socket.
Technology,
oh,
it happens. Thanks for
good.
bearing with us on Zoom.
Dislocation nationwide is considered 3%. The
Okay,
problem that we have
just
is
a
there
minute
is
here.
literally
No
no
problem.
hip
You're okay.
replacement made that.
Okay.
Got
Let me
it?
see where we're at here. Okay, so for anyone that's left, I've been talking for a while. I'm not sure if anyone's heard me. What's the status update, Sydney?
We did hear you. Excuse
was
me.
that-
There were a couple of wonky things that happened in the middle there. So we do apologize that the videos didn't show, unfortunately. So we weren't able to see that. So
Okay.
thank you for recapping that second one.
Sure.
And then we did have some weird stuff in the middle, but thank you all so much for your patience. Zoom is an interesting world, as you all know, and we're still getting used to it too. We'll put it that way. So, all right. But we do have a few more questions, Dr. Mulder, if we want to go
Sure.
through those. I think
Of
those
course.
would be great. Also, once we get through the questions, I do have a list here, but for those who are listening, if we want to unmute and ask the questions, we can definitely do that. Feel free to, since we have about 5 or 6 of us on this call here. But another question for you is, what precautions are being taken now during the COVID pandemic?
Yeah, that's a very astute question. So it depends on where you have surgery and when you have it. So right now, St. Cloud Hospital is, I think, very appropriately limiting scheduling new cases, that is, cases that aren't emergencies. If you do have your surgery done at St. Cloud Hospital, you would get a COVID test about 2 to 3 days beforehand. And then assuming that COVID test is negative, then you go forward with your surgery, quarantining between the test and the surgery. In a similar way at St. Cloud Surgical Center, we're doing a COVID test a couple of days before surgery. Assuming that test is negative, then you'll come in, you'll quarantine from the test to the surgery and then come in. At the surgical center itself, all the staff are wearing masks. During the operation itself, when you're going to sleep and waking up, everyone in the room has a special N95 mask that prevents the spread should the test have been inaccurate. And so in addition, we're screening at the door at the surgical center. Every staff person that walks in gets a questionnaire about symptoms, takes their temperature. And so really, I think like in the day and age, we're using the precautions like the masks, hand washing, testing ahead of time. And that's really the best that anyone can do. I think the nice thing about the surgical center is, theoretically, there's less risk of exposure. There's no one hanging out with COVID. There's no one hanging out with pneumonia. It's not a hospital. We treat healthy patients and have in and out surgery.
Awesome. Thank you for that. That was very thorough. Here's another one. How long will the joint last?
Good question. So typically speaking, knee replacements without any issues should last roughly 20 years. Depends on a lot of circumstances. Hip replacements, I typically think of lasting about 25 years. Now, if you are a marathon runner and you keep doing that, you may wear it out sooner. But generally speaking, if you're in your late 60s, early 70s, I generally I don't think you'll need that hip or knee redone. They tend to last about 2 decades, sometimes 3. And getting back to the previous question as well, at the surgical center, they've also got, in addition to the robot for surgery, they've got a UV light robot. So between surgeries, there's a UV light that's buzzing the room that kills anything that's living as well. So that's sort of an extra step in addition to the wiping down of the surfaces, et cetera.
Okay. Okay. How about what can be done to prevent infection?
Yeah, that's a good point. It's something that's always on my mind. As a specialist, I see a lot of people that have had problematic hip replacements, knee replacements, infections, so I treat them. I think that makes me kind of neurotic about wanting to prevent them. Before surgery, you'll do about 2 or 3 nights worth of a chlorhexidine or a special soap scrub on the joint or the hip or the knee area. We do that right pre-surgically as well. We give an antibiotic within a half hour of surgery and 1 dose afterwards. In certain cases, we might give an oral antibiotic, a pill to take for a week afterwards. And then another thing that we know helps prevent infection is efficient surgery. The longer you're in the operating room with that incision open to the air, the higher the risk for infection. And the robotic system shaves off, I haven't done one without it in a while, but it shaves off, 10, 20 minutes because it's a 1-step process and you don't have to repeat steps. You don't have to check with an x-ray during the surgery. So the more efficient surgical procedure is another way to prevent infection.
Okay. Yeah. Anybody who is listening, please feel free to ask questions. You can ask it in the chat if you're uncomfortable doing mute or video. So feel free to ask those in the chat and I can feed those to Dr. Mulder as well. But at this time, what are maybe some more common questions that you've heard, Dr. Mulder, that you get quite a bit that you'd like to cover?
Well, I think that what I get a lot is when people come to the office that have had sort of a new onset of symptoms, say they were doing fine for the last 10 years. Last Tuesday, they woke up, they couldn't even walk. Their hip hurt so bad. They come in, we get x-rays, do an exam, talk about their history, and I show them and I say, hey, you've got pretty bad arthritis in that hip. And they say, no, I don't. It just started hurting Tuesday. I've never had a problem before. It's actually really common to have arthritis. Either it was slowly progressing and you really didn't notice it. And then for some random reason, maybe you rake too much, maybe you golf too many holes, maybe no reason in particular, it just flares up really acutely. So I think that's a pretty common thing for people to experience, is where you can have arthritis for a long time and not have it be a problem. And then all of a sudden it flares up. Okay. So that's something that people are often surprised by, but I see relatively commonly.
Good to know.
I think the other thing people ask about is the recovery, which we've covered a bit. And I think generally speaking, hips recover a little bit easier than knees. And in the end, assuming everything goes well, you have a good chance of improving your quality of life with both. At the end of my talk, I did cover, whether or not it was seen, I don't know at this point, but I covered a little bit about some of the cost differences potentially between surgery at an outpatient setting like the surgical center versus at the hospital in an inpatient type setting. And if there are specific questions about that, reaching out to the St. Cloud Surgical Center business office, based on your insurance, questions about copays, what the overall cost is, they're a good resource for figuring that out as well.
Okay, great. I don't have any more questions at this time. Just take a peek.
Another common question I get is, say you have some arthritis, what can you do about it? How do you prevent it from getting worse? Are you hurting it per se by being active and trying to do things? And I think that in terms of preventing arthritis from advancing to the point where you need a joint replacement, some of it is luck. It's going to happen or it's not. And I think a big part is trying to stay active. Joints like weight-bearing activity. They like to be moved. They like the muscles around them to be moved. And so the people I see that have the worst arthritis on x-ray that aren't getting hip or knee replacements are people that maintain a healthy body weight, find a way to stay active in whatever way they can. And I think, as long as you eat vegetables once in a while and get the vitamins and minerals you need and the calcium and vitamin D, that's the best way to prevent it. I think a magic cure with stem cells or blood injections or I don't know, lasers, whatever you want to use. In the early stages, some of those biologic agents can be effective. I think in the late stages of arthritis, to me, I don't understand how they can possibly regrow cartilage when there isn't any to begin with.
Sure. Yeah, great point. All right. If you have any other final thoughts, otherwise I'll talk about the consultation form.
I think that, overall, arthritis is a very common condition. If it's really affecting your quality of life, that is, if you're missing out on things you'd otherwise do, if people are off going and doing this or that, and you're saying, no, I got to stick back because I'm going to slow everyone down. I'm going to have to find a chair every 10 feet. I don't think that being too young or too old is a good reason not to pursue treatment. It really depends on the situation, and it can really be a life-changing thing. And that's one of the most enjoyable parts, is when I see people that really get their hobbies, their lives, and their joy back in life, because it's pretty depressing to be hurting all the time.
Yeah.
So thank you, everyone. If there's any questions, please send them. I apologize for the technology issues. I think that was probably user error. So thank you for bearing with us.
Yeah. Thank you so much, Dr. Mulder. We so appreciate your time and you being willing to do this. For those that are listening at this time, or those who did sign up for the class and may watch this later, tomorrow you will actually receive an email that has a link to the consultation form that you can receive and be able to fill out more information. This link will actually go to the St. Cloud Surgical Center, and someone there will contact you after. So make sure that you check your email for that. Make sure you check spam, but you should receive that if you have enlisted for this. And then finally, again, thank you so much, Dr. Mulder. We so appreciate you being willing to navigate Zoom first off, because got to provide value somehow during our time at stay at home and during COVID. And so this is good. So thank you for just being willing to jump into the water and do this. Thank you to everybody who's been watching tonight. We so appreciate your time and being willing to do this also at night. And other than that, we'll see you later, and we'll see you. Stay tuned for the next webinar, which we'll talk about a little bit later, but have a great night. Thank you.
Thanks. Have a good night, everyone.